It's a great honor for me today to have a phenomenal webinar, and I'm happy that it is an ISAR, ICOG, Bharat Serum, and Science Integra initiative, which is mainly for educational purpose. We will have the dynamic Mandakini Meg, who has so many positions all or in various organizations. She's a very popular person, especially known in administration and government side more. Most important thing is she's the ICOG chairperson. So I will request Dr. Mandakini Meg to tell us a little bit about ICOG problem, ICOG progresses and ICOG things, what are being done. Then the chronology I'll be explaining after she finishes.
So, good evening, Prakash, for that beautiful introduction. I'm very, very happy at the outset. I want to say that I was very pleasantly surprised also. And it's very nice that you called me and we were suddenly associated with ISAR. And it's a really privilege for ICOG also to be associated with ISAR. And as you friends, you know, this ICOG is Indian College of Obstetricians and Gynecology. And this Indian college, the main aim is to promote and propagate the knowledge and the education of medical education in the subject of obstetrics and gynecology. So this is very important, and this is a teaching activity of ISAR. And I will request Prakash to, whenever there is a chance, we give points also. We are awarding ICD points also, which is also very prestigious, and we will like to be associated with many other activities. So friends, this with the aims of education and training, we want to say that at ICOG we are conducting many training programs for the postgraduate fellowship, and those training programs are in very important activities like reproductive medicine, fetal medicine, then ultrasonography, then cytology, colposcopy, contraceptive family welfare, and so on and so forth. Very, very prestigious. And after post graduation, many of the people are joining. And I must say that today's ISAR people, I want to say that reproductive medicine, even Prakash has got the center, is very, very popular course of the ICOG. And it is the icing of the cake in the course of reproductive medicine. And also, I want to inform all of you that we have around 24 center with the 2 fellows each, makes around 50 fellows who are taking course. And I think it will be very good seminar in the COVID times for them also, because their education is halted because of the this COVID. So I just want to conclude by saying that we have just started the reproductive medicine online course. Prakash, you also promote people to join that course. You also be the faculty. There was also faculty, and let us make a very popular program of the ICOG. One more thing I just want to say, that our college is affiliated to the prestigious Royal College of Obstetricians and Gynecology, and for the students' sake, ICOG worked so hard that they have brought MRCOG Part 1 and Part 2 directly to the Foxy office. So we need not go to the UK or anywhere to give the exam. So it is so nice. So friends, I want to invite you, those who are eligible, also to become the prestigious fellowship that is the FICOG. With these concluding remarks, I again thank Dr. Prakash Trivedi, my friend Firoza, her son Dr. Parikh, and everybody. And it is going to be a very, very informative symposium. And thank you very much.
Thank you, Dr. Mandakini Meg. We are happy to be associated with ICOG, and this webinar is a little bit very prestigious and unique, for the simple reason is that ISAR along with ICOG and Bharat Serum Initiative and many other things, we have 3 important talks, and I intentionally selected the talk which is something like an old is gold type of talk. So I'll be speaking on how I use GnRH agonist today, something about COVID. After me, there will be a presentation on all that you have to know about COVID as a clinician, and that talk will be given by Dr. Swapnil Parikh, who is an expert on COVID, has written a book on COVID. And to be very honest, I started reading that book at 6 p.m. on Sunday, and I finished at 3:30 a.m. After that, Fertility in COVID Times will be by Firuza Parikh. Firuza Parikh is known to everybody. And we'll have enough time for question and answers. Everybody who has a question and answer related to agonists, COVID and laparoscopy, COVID and IVF, and COVID and something else, or whatever you feel worthwhile, please don't hesitate to send it. We will be answering each and every questions. Starting with something very important, obviously most of the people identify me being a primary laparoscopic surgeon. And when it comes to a depot, this is the scene which comes in my mind. A 26-year-old female, just married, has a 20 centimeter fibroid. There is not the IVC, but that's the ureter. And she's having a hemoglobin of 6.9. So obviously we build these patients. Quite often we give depot so that it gives enough time to build. With availability of FCM, the need of blood transfusion has been reduced drastically. As we have ART consultants who are exemplary in India, vaginal surgeon best in the world, probably India has the best group of laparoscopic surgeon who can do a myomectomy of multiple fibroid, large fibroid, and multiple in number. The important thing, however, we have to realize that most of the laparoscopic surgeon will not prefer to give a depot when you do myomectomy, because the tissues do merge with the planes. The other group wherein we give a depot is when we are doing hysteroscopic myomectomy of more than 5 centimeter fibroid and she is anemic, so then it can be useful. It's very important to note that largest number of fibroids and the maximum number of fibroid and all this record goes to India. And we are extremely happy that in-bag morcellation of fibroid and uterus with fibroid, the largest series in world we have with me, along with our team, which is around 486 cases, which is the biggest research which was acknowledged by AAGL. I'll not go into the technical details because all these fibroids are removed in a bag. We had to remove something yesterday also, but I will focus on to the primary thing, which you have to remember that GnRH agonist obviously was born much before IVF. So it was way back in 1972 when a synthetic GnRH agonist was made. To understand the role of agonist, I think so we have to understand that gonadotropic hormones are produced and secreted by the neurons, which are situated in the medial basal and the preoptic region of the hypothalamus. And then through small capillaries, it goes and it stimulates to have production of FSH and LH. Of course, this being a decapeptide, the half-life is not that very long. GnRH is released in pulsatory fashion, and this is there even in the child in utero and remains in infancy till she becomes an adolescent, somewhere around 8.5 years onwards. The suppressive effects on these gonadostats are removed, and then you have the possibility of the effect of stimulation which can come. Now we all are aware that if there is an estrogen progesterone rise, there will be a negative feedback as far as GnRH secretion is concerned. However, in normal physiology, prior to ovulation, even rise in estrogen doesn't block. On the contrary, it allows an LH surge to take place so that you can have an ovulation, and if they're planning, probably conception can take place. GnRH has a short half-life. As I told you, it is 2 to 4 minutes. And the sole reason that GnRH agonists and analogs were used for the agonistic properties is to increase the potency by substituting few of the amino acids, probably from 6 and 10 position, and thereby it causes the desired effect. There are many GnRH analogs available. I will not go into details of the trade names of each, but each analog has its own value and its own utility. Increasing their affinity with GnRH receptor and resistance, there is a proteolytic degeneration which takes place. Now, GnRH agonist in terms of mechanism binds with the G protein coupled receptors, and pituitary initially leads a overreaction, a cascade of events causing upregulation of the receptor, what we normally call it as a flare effect. So when you're giving it, there is a slight increase in the activity, which can be used in some situation when people have different pattern of stimulation. But largely, when this prolonged activation keeps continuing, it desensitizes and brings the down regulation and suppressing the gonadotropin secretion, and obviously leading to many other things which can be beneficial. Now, what was the problem in 70s? When people were thinking about ART, though the success may be on July 78, but 20% of the ART cycles used to be cancelled because of a premature LH surge. And that is why GnRH agonists were manufactured so that it can take care of reducing the cycle cancellation and utilizing in a normal responding female, or maybe wherein you want a suppression wherein it is a young with good AMH and it's going to respond much more better. So then GnRH agonist can be useful apart from many other uses. As I told you, we use in fibroids and many other situations where it can be used. The old rule of 5, which was, all these rules are made to be changed. For down regulation, it was less than 5 follicle. It was less than 3 millimeter actually, 5 millimeter endometrial thickness, less than 5 millimeter follicles, less than 50 E2, and less than 0.5 progesterone. So this was the old rule of 5. There are a lot of modifications which we individual centers will have, but for a long period of time, until even recently, many people do prefer a long agonist in different situation. Even there are good data in poor responders. Long agonist protocol is a very classical, simple protocol. Not necessarily everybody will give an oral contraceptive in the previous period, but ideally an agonist is given usually 7 to 8 days after so-called ovulation, or 8 days prior to the expected period. Once this is given in a proper dose, which is the full dose which is given, then after the period established, that rule of 5 is followed and we see that there is nothing which is skipped. Then the gonadotropins are started. On an average, 9 days of stimulation takes place. It varies from people depending on AMH, BMI, and multiple factors, especially age. Then a trigger, usually that was HCG at that time, pickup, embryo transfer, and progestational support. Now, GnRH agonist, as I told you, in normal responder and little bit more responder will give better synchronization of follicle, more number of follicle, less cycle cancellation rate. And in poor responder, it was always a myth that it may over suppress the LH. However, there are plenty of current meta-analysis which clearly tells that a long agonist protocol gives good pregnancy rate, better M2 oocytes, and typically you don't have to worry because it is a poor responder. You're not worried about ovarian hyperstimulation, multiple pregnancy, which should not be an issue. However, antagonist is there for here to stay, and it has its own advantages, which we always utilize. If we see ART practice, and I am witness to being primarily a sonologist before 80, then after 80 onwards, after 90 in 80s sonologist, 90s onwards endoscopy till today. I'm still more focused to endoscopy. Thanks to Mrs. Preeti Trivedi, my wife, who's an embryologist. So 20 years we have ART practice. Obviously, we pick up a lot of things from people like Firuza and many other experts all over India and all over the world. Past conventional stimulation was more number of oocyte, more embryos, and obviously it meant OHSs and sometimes multiple pregnancy. Present time, it may be a little bit optimal stimulation. We don't want too much. So just adequate number of oocyte, free from OHSs at least. Obviously, the number of embryos transferred has drastically changed. And this change is because of four important things. One is the knowledge of ART clinicians, the embryology knowledge, the quality of media, and decoding many aspects and getting better and better molecules which can be beneficial in spite of the fact that the fertility is increasing, and obviously the male factor goes on rise. And also with AMH coming in, we started realizing that there are more and more younger people who may have a lesser AMH. So in future, obviously everybody wants a single euploid embryo to be transferred, and obviously nobody wants multiple pregnancy. One important thing in an antagonist protocol, if you are following, which is a good protocol, I will not go into antagonist protocol because that's not the agenda of today's discussion. But if it's an antagonist, and then you can, there are people who give CC gonadotropin antagonists, there are people who give gonadotropin antagonists from day 6, etc. Agonist can be used as a trigger, and this is extremely useful because there are too many follicles, like in a PCO patient. When there is a good response, then you have so many follicles. So you can give a GnRH agonist trigger, and occasionally 12 hours apart depending on the dose. The most important thing is this trigger is given intentionally to prevent OHSS and also to freeze all the embryo, because so many of oocytes are present, the milieu is totally deranged and you are not really sure whether you want to transfer an HCG rise and then come across a situation. Obviously, a trigger doesn't work if it's a long suppressed cycle, and trigger doesn't work if you have a hypogonadotropic hypogonadism as a case. Frozen cycle is the call of the day. Obviously we are not telling exactly in COVID time that we are going to do all these things very actively. Tomorrow is apparent time when the lockdown was to be lifted, which all of us are aware it is extended, but there is some respite that the clinics etc. can open. In frozen embryo transfer, giving a depot prior is definitely useful. It gives better preparation for the endometrial lining, better pregnancy rate, and it avoids cycle cancellation. When you're talking about analog, you can never forget the disease of the millennium, and that is endometriosis. And though there are so many drugs which are there is definite role of a depot or an analog we use analog in an inflamed endometriosis or endometrioma, wherein typically when you're doing a clinical examination, there is tenderness. When you do a sonography, there is pain. She gives complaint of dyspareunia. She keeps complaining of painful period and lower abdominal pain. Now, it's not necessary that she has come for infertility only. And it's a golden rule that if you have a younger lady, you will think of surgery last. So, inflamed endometriosis, frozen pelvis, previous abdominal surgery, then sometimes going with the laparoscope, you may not benefit much. Recurrent endometrioma, rectovaginal endometriosis, and every day is not the same. For years and years, you may do a good surgery in endometriosis. Once you have an advanced endometriosis, and probably you feel that your entire surgery may need maybe a month's depot or 2-3 months depot. And obviously, prior to stimulation protocol suppression, and there are many people who do believe in a longer suppression in cases of endometriosis. The other time, me, Pratap Kumar, and many others were on discussion, and he highlighted the importance of reducing inflammation, reducing many other factors which may be coming in the way with respect to endometrial receptivity in a patient of endometriosis, which can be again brought to use. Obviously, I'll not be going into detail of the surgeries of endometriosis, but I think so endometriosis is a very sticky disease. Extensive endometriosis, no matter how great surgeon you are, you can never say that you will achieve excellence in laparoscopic surgery in endometriosis. You may do an excellent surgery, recurrence is assured. You may do a surgery, and according to me, 75% of the surgeries done for endometriosis by even known laparoscopic surgeon, where occasionally I may be also a part, is sometimes not the right surgery. These are two patients, both were sent to me by an ART consultant, and both were given a depot prior 2 months. And you can see how nicely you can peel off the tissue. The tissue becomes, dissection becomes good. If you saw, in fact, the one on the left side, she is a gynec, wife of a gastrointestinal surgeon, but properly the ART consultant had prepared her, and if you see, the anatomy is restored. So quite often you have patients who come prepared taking a depot. When it comes to stimulating endometriosis, there is only one simple thing I will tell, because we don't want to go into too much of details of stimulation. But if the patient is having good AMH, good AFC, one of the good thing is to give on day second a 1 month depot, and you may think of adding estrogen on day 25 of the cycle, and then start with FSH day 2 to day 6, add HMG on day 7, and then do the rest of the thing and use progesterone support. Of course, if it is more than 35 years, your stimulation protocol will vary. You are really not interested in too much of suppression. You may start with higher dose of gonadotropin and then consider antagonist, and then work how you would like to plan the things ahead. Recombinant as a trigger in antagonist is definitely useful. And if it was really a poor responder, then testosterone used as a gel in the prior month, but that goes out of context of the current topic. Obviously, the depots have plenty of uses. It's not necessarily endometriosis, fibroid, a lot of use in IVF. Prior to endometrial ablation, which we started, though I didn't use in many cases because we mastered the art of multi-layered endometrial resection. I remember my great friend Rakesh Sinha on this time, who was also an excellent hysteroscopist, and also not to forget Mandakini Pariyar and Praveen Patel, whom we lost earlier. Precocious puberty, you can use depot till they reach to suitable age, hormone dependent tumors, then hirsutism, fibroid, and there can be other indications for you using. I'll be briefly talking to you. I just jumped in because prior to this I was addressing an endoscopy forum. And thanks to reading the book with Swapnil Parikh, Myra, and Rajesh Parikh had, my understanding of endoscopy has become good. Fortunately, uh, inspired by Eamon Parikh many years back, I did a post in anesthesia. So again, that helps now in COVID times to decide. And today, I'll be listening a lot from Swapnil Parikh. I've read the book and made a lot of notes. Uh, we have to remember that when the lockdown was there, obviously only emergency surgeries, which may be ectopic, spontaneous abortion, tubovarian abscess, torsion. Cancer patients wherein benefits of waiting for 6 weeks were doubtful, then that can be taken into consideration. One very important thing which I told the previous group, and I was very surprised when the guidelines of the Association of Endoscopy started promoting open surgery. And this is an excellent paper on 3rd April 2020, which clearly shows that scope of scopy in COVID-19 has to be evaluated. I personally feel it's impossible for a small particulate to go into the respiratory system or to go into GI system and then using a host cell, and after that being gulped by WBC, can directly be expressed in peritoneal cavity. So a harmonic generating smoke, the plume with cautery and all. So there's a lot of misunderstanding people have because we don't go into the depth of COVID, and we should definitely go into the depth of COVID because I went through the Kindle version of the book by Swapnil and I started understanding. So converting into laparotomies, you're going to add more hospital stay. There'll be more incidents where the patient and the relative can come in contact with somebody who is having COVID, and you can do a lot more harm than doing a proper endoscopic surgery. And some tricks with endoscopic surgery I will tell, because at some stage, we are now on 2nd May, we will be on 2nd August sometime. At some stage, we are going to enter into doing regular cases wherein we will have to have our own protocol. And when I added something to the previous group, they were really surprised because they were actually having entirely opposite views. Now, frequent air changes is advised in the operation theater, which is very difficult when you have a hospital. We have 3 operation theaters, one IVF, one 3D, and one another one. So it's not easy. And when you're having frequent air changes, you're taking air from outside. Obviously, positive pressure is useful. Proper cleansing, fumigation, filters, each and everything is very much necessary. We have the fumigators which have hydrogen peroxide, and also sodium hypochlorite is one of the agent which is now most commonly used in wiping and spraying in many situations. Intubation is a big issue, and I asked actually to AGL and the entire group whether we should do a swap from the anesthetists, because they are the maximum people who move around to multiple area. And one of the important institute in America, they told that we have 1,000 kit and 200 hospital staff. So apart from the anesthetist, the OT tech, the sister, the consultant, then you will be utilizing a lot of our resources. So unless and until somebody is actually symptomatic, you need not actually rush for the test. You have to remember, a lot of anesthetists of our place who are advanced in age are rightfully not coming for an emergency cases. The OR team which enters the OT is after an intubation is done, not from before, and number of persons are totally limited. So you have a surgeon and an assistant, an OT sister, and OR tech. And as about the gas and the plume, as I told you, one is you don't worry too much unless and until there was a case, I do remember it was in Jaipur, wherein there is a bowel perforation with COVID positive, and they operated and then everybody got the COVID infection. But I'll be showing you some simple thing. In anesthesia, the 2 incoming tubing has a filter. The tubing where the tube is connected has a filter. The CO2 which comes from the cylinder, which doesn't manufacture any COVID, has a filter which goes into peritoneal cavity, and unless proved otherwise, a particulate material of such small size which needs a host may not be floating around unless there is some definite infection. But what we have done is our suction goes into the bottle of the endomat, which has sodium hypochlorite, which is connected to the endomat suction. And also one of the port, which is the gas evacuation port, the of the four port, the port on the right side is connected to a filter, to a tubing. It goes into the bottle of endomat, which has sodium hypochlorite, and which is taken away. So you can have minimum spread and you give quality services. During this period, we had an ectopic, we had an appendicitis. Yesterday was an emergency hysterectomy which we had to do because patient was scheduled for 12th, and exactly on 12th March, after that, then she could not wait and her hemoglobin was good for the first time. Obviously, we do an in-bag morcellation, which is an added advantage, so it doesn't spill. Low pressure Trendelenburg, and as I told you, is not really necessary. As I mentioned, and of course, Swapnil will be adding it more in detail. It doesn't go through blood, so sexual contact. So if it is COVID, it is going to be in the cell of the respiratory tract or in the throat of pharynx or in the GI tract. And once it is taken up by the WBC, it can go into the circulation, it can go through hypothalamus and cause many things. As far as the energy is supposed to be used, everybody who are against the energy are now jumping about energy sources. According to me, energy source generates good amount of heat and they are vessel sealers. So the tissue which you are separating, you are not allowing any contamination of the blood. So on the contrary, that is better. And the temperature which it has, no virus is going to survive. Coming to the most important aspect is tissue extraction. And tissue extraction, as I told you, we have 480 cases of removing large fibroid, multiple fibroid, all inside a bag and under vision. So there is nothing of the peritoneal cavity which is exposed, and we were happy that in November in Vancouver, it was claimed as one of the major research breakthrough. There are many other things which we know that a fibroid doesn't develop into sarcoma, which is not under the purview of today's talk. When you're taking out the tissue of the abdomen, when you're doing it laparoscopically, you should close all the inflow, open the outflow which is going through the filter, going through the bottle, and then going into the suction. So it will take care of all the thing which is not actually entering into your operation theater. Now, if you can see here, this is a small little thing, 2 filters at the anesthesia, 1 filter where the tube is going. This back filter is very important because the expiratory volume of the patient will come and it will infect this canister. So you have to be very careful. Obviously, all these things are thrown after one case. As I told you, this is an totally a method which we have decided. We have air seal and many ready systems available. This is the Myamic by a large fibroid when we were doing yesterday, and one which we did much earlier wherein patient just couldn't wait. We use all the standard precaution, and one precaution, as I told you, 2 endomats, these 2 outflows. So one is the gas which is going, but the other 2 is, one is connected to the suction and the outflow of this goes into one of these bottles. So it goes through sodium hypochlorite, which goes into the endomat. The same way, the CO2 gas inside will go through a filter. Here the filter is not seen attached because I had to open a brand new filter. So filter is attached, so gas goes through it and again goes through another endomat bottle, and it goes through ULPA, which is a low pressure suction device. So all these things you have to work out and keep thinking. You have to take care of immunocompromised patient, symptomatic person, patient with high BMI, BP, diabetes, special protection for the anesthetist ENT person. We have to remember Just the other day, I and Firoza were talking when I was about to join one of the AAGL webinar, and it was heartening to know because we had people from China, America, from Italy, from Spain, Beijing, Shanghai, Wuhan, and Wuhan, a lot of things. Swapnil will be talking. Texas, North Carolina, etc., have started their cold surgery with a very strict protocol. With some patients of cancer which cannot wait, some patients of uncontrolled bleeding where the person is having no relief with respect to her bleeding and needs much more than just medical treatment. However, you have to be very clear that the accompanying person and the patient has a detailed interview taken by your receptionist or the secretary, and when they are giving appointment, they are giving appointment which are spread out. We have a big waiting room, so you can have 6 patients sitting at 3 meters or plus distance. The temperature check is done. The sanitizer is given. The consultant also has limited number of people inside, one sister and maybe one assisting person, everybody with proper gears which are needed. When we are going to go back into which is what is expected, that they have told that the lockdown will continue, but people can open up. Now, for any planned surgery, what we were doing about for this fibroid also, we did her COVID test 3 days prior, kept her in isolation. We finished the surgery. We had another similar patient on 7th or 8th day. When she came back, she was known to us. She didn't have any symptoms. She didn't have fever. She didn't have cough or anything. Then when we do suture removal, that is the time when we do IgG and IgM and see that she is not positive. That means she was not positive when she came. Hospital has taken a clear undertaking that it is not through hospital, though it is possible that one can have this taking place. You have to be very strict. Life after COVID is going to be absolutely different than what life was earlier. Uh, as as we stand today, we have 34 lakh patients of COVID all over the world, with nearly 2,40,000 who have died. America itself has 11 lakh patients and 66,000 who have died. India 37,336, 1223 died. It's important to note that the test done in India is 9.7 lakh and 67 lakh in America. Still, America has alarming number, because though in India number of tests are not more, but once the test is positive, and we must admire the government and Modi, Mr. Narendra Modi, that he brought in appropriate lockdown, and he has taken measure, and they've pumped in a lot of money. There are a lot of people who are having some problems or the other as far as the livelihood, etc. is concerned, but in larger interest, where the figures could have been. In fact, I heard one person that even if the lockdown was delayed by 1 day, it would have led to much larger figure. Coming to the most important point, in such time, and I read all those 100 years of pandemics and so many other things from Swapnil book, you have to remember that you can run a sprint. You can also run a marathon. Now, sprints are opinion coming from various people who don't have much knowledge. And so you cannot sprint a marathon. So we are having a marathon which is going to take a time. It's going to take sufficient time. In this period of time, you have to find out what is safe for us, what is safe for our staff, what is safe for our family. Learn from expert like Swapnil, learn from intensivists, learn from China, learn from Italy, learn from everybody, and see that we make this everything safe. Obviously, not to forget that we want to get back to work, but what work we can do should be accountable for. I take this opportunity to thank everybody, and usually we have 1,000 plus people normally, and we are more than happy. And I can assure you that next two talks will floor you down much more than what I have spoken. And I would like to introduce the next speaker. This is I have a bad habit of taking a book in a flight, and even if I'm going to America, I finish the book in the flight. So this happened on Sunday evening when I took Swapnil Parikh's book on All You Want to Know About Corona. I started at 6 p.m. on Sunday and finished at 3:30 a.m. Swapnil is a phenomenal internal medicine expert, certified clinical research in biostatistics, author of the world's first book. Probably, if I'm not wrong, 2nd April was when it was released. Lots of people have read. I would suggest many of you who are interested, read it to understand so you don't have inadequate knowledge. Focus of area, pre-pandemic area, telemedicine, infectious disease. Pandemic time, he has been very active in SARS-CoV-2, COVID-19 response, co-investigator, Maharashtra convalescent plasma for COVID-19, clinical trials, and a principal investigator in BMC for the pilot study on waste water water surveillance in SARS-CoV. He is, of course, an important advisor at Jaslok Hospital and Municipal Corporation of Greater Mumbai. Inventor of safest. The safest is safe and fast evaluation swab test. This is something exceptional which everybody of us will like to know. Inventor of safe assessment, fast and effective resolution clinic, and co-founder of DIY Health, a pandemic time healthcare solution that AI powered, artificial intelligence powered by human centered, and obviously he's a young dynamic person, and all of you are looking forward to hear from him. I am on the contrary looking forward more to look at what he's going to talk and then what Firuza is going to talk. I pass this mic to Swapnil Parikh. Swapnil, pleasure, and invite you on ISAR, ICOG forum, and the screen is yours and the time is yours.
Thank you so much, sir. It's a pleasure and an honor and a privilege to speak in front of you all. I'm much younger and have far less expertise than most of you all, but I will try to share whatever I have learned while writing the book. Thank you all for having me. I'll just start. Are you able to see my presentation?
Yeah, we can see it now. Yes.
So this is the book I've written. This is just a little bit about me, but I think Sir has already done a great job about introducing me. So I want to start with the virology. The SARS-CoV-2 virus, it's a beta coronavirus. It's related to the SARS-CoV-1 virus. It's a single strand positive RNA genome. It's enveloped, it has a bilipid layer. And most likely, we think it arose from a bat coronavirus. There was possibly an intermediary animal like a pangolin. We really aren't sure. Just a little introduction in video.
Named COVID-19. The virus causing this disease is known as severe acute respiratory syndrome coronavirus 2. The disease spreads through small droplets that are expelled from the nose or mouth when a person with COVID-19 coughs or exhales. Therefore, standing close to someone who is infected can put you at risk. These droplets can land on your hand and be transmitted through something as simple as a handshake if afterwards you touch your eyes, nose, or mouth, the so-called T-zone. The virus is known to survive on different types of surfaces, so touching these contaminated surfaces and then touching your T-zone brings a high risk of infection.
So, want to dip into the epidemiology, the geographic distribution. In my book, we have a chapter called Around the World in 80 Days, in less than 80 days. It's a play on a Jules Verne novel. The virus started, the first confirmed case was in December in 2020 in Wuhan. But based on mathematical models about how quickly it spread, it's likely that there was the initial outbreak started sometime in mid-November in Wuhan. By January, it had already spread across most of China and started to spread across the world. And in less than 80 days, it had spread to every continent other than Antarctica. And the virus that started in Wuhan had reached Iran. And when a passenger traveled from Iran to China, he actually re-imported the virus into China. So, it traveled around the world in less than 80 days. Currently, as Sir pointed out, over 3 million confirmed cases, over 2.2 lakh deaths worldwide. I want to briefly mention we have to make a distinction between confirmed cases. These are people who have tested positive on a lab test, and the total number of infections. Studies show that the total number of infections may be 10 to 20 times higher than the total number of cases. And this is a real problem because it can spread silently. We don't even know everyone who's infected. And these people, although they may not seem very sick, can still infect at-risk populations. In India, the official government figures peg us at about 25,000 confirmed cases. Other sources say we're as high as 35,000. Again, I just want to reiterate, these are the confirmed cases. That does not mean that this is the total number of infections. A little video, which I think kind of represents what the worldwide response to COVID-19 has been, how it shifted from an initial period of disbelief that this is nothing to panic.
Kolla här.
Det var sådär en lavin eller?
Ja, den är kontrollerad.
You can see an avalanche starting and people are wondering.
Det är som en jäkla krafter.
Är det safe?
Ja, de vet vad de gör.
Pappa!
Ja, det är ingen fara. Harry, det är lugnt, Harry!
So what does this video tell us basically? That, COVID-19, it's a disease caused by a virus that really moves faster than us. And no matter how fast we move, we're always going to be a step behind it. So we have no time to think like, let's wait till it's obvious that it's a huge problem to react. We have to react as quickly as we can. And if a few months from now, we find that we overreacted, that'll be our best case scenario. Everyone will be really happy that we overreacted. If we underreact, it'll be a disaster. Just to touch upon the transmission, the modes of transmission. Basically, we know that this primarily spreads via droplets. Droplets refer to particles that are more than 5 microns in size. If they are less than 5 microns in size, we call them droplet nuclei, and then it's something called aerosol. What we are finding is that there's a bit of a false dichotomy between these two, that there's a spectrum. Some people, even with the same virus, can cause aerosols. Certain activities can cause aerosols. There's good data to suggest this. Direct contact, as we saw in the prior video, can do it. Fomites are another route. Fecal oral route is something that is being investigated. We aren't certain about this, but it seems likely. Vehicle-borne food, milk, water, bodily fluids, potentially, we're not sure. As of now, there is no evidence to suggest there is vertical transmission, but there hasn't been enough research on this. With sexual transmission, again, not enough research done. The period of infectivity can start 2 to 3 days before the onset of symptoms. So in the incubation period, people can still be infectious. And there is some evidence to suggest that people might be infectious even after symptoms have subsided. And we know that asymptomatic individuals could be infectious. And in some studies, up to 60% or 70% of individuals have been asymptomatic or pre-symptomatic when they already had a positive test. This next graphic kind of demonstrates how droplet and droplet nuclei spread works in a plane setting. So you will see when there is a cough or a sneeze, there's a wide dispersion of these particles that can then transmit the infection to everyone in the plane. This is actually a study that was done in China at a restaurant. So you can see the table in the middle had a patient who was infected. That patient coughed and generated droplets. You can see the AC vent in the upper right corner. The draft from the AC pushed the droplets towards the table on the left. It hit the wall and it spread back towards the AC. So you can see how drafts of wind can make droplets that we think only spread up to 2 meters. They can make them travel much further. So it's just something to be aware of. Another area that is very interesting and has had some controversy is how long can the virus survive on objects? So studies show that in aerosols, and this is in a lab setting, by the way, so some of this may not apply to real world scenarios, but aerosols can survive, the virus can survive for up to 4 hours. On copper, it can survive for up to 4 hours, which is why I've actually switched to copper bottles, drinking bottles. Cardboard, like if you receive a package, it can survive on that for up to 24 hours. On stainless steel, 72 hours. Plastic as well, 72 hours. On glass, potentially 96 hours. So we're not sure how infectious these virus particles will remain, but it is possible that these items could transmit the infection for a while. Just to show you a graphic with all the different objects, you can have a look at this and see, where these, what can transmit this and for the time periods. To just touch upon the pathogenesis briefly, how does it make people sick? How does it make people sick? How does it kill? Right now, the S protein or the spike protein, we know that it uses the ACE2 receptor. There are other potential receptors. We think it uses L sign, DC sign, possibly the FC receptor. The virus can have direct cytopathic effects. The immune response it causes can become unregulated and cause a cytokine storm. Another emerging theory is venous thromboembolism. So, Workhouse triad of endothelial damage, hypercoagulability, and stasis of flow. When the virus targets cells with the ACE2 receptor, it can cause all three. The blood vessels, the endothelial cells are very rich in ACE2 receptors, and it can cause workouts, all the factors in Workhouse triads. And we are increasingly seeing that thromboembolism and especially pulmonary embolism is an important factor. What we are also suspicious of, and this is speculation at this point, is there might be an element of what we call immune enhancement or antibody dependent enhancement, which is well studied in the dengue virus, whereby the immune response itself can stimulate, can facilitate viral entry and infection. So this is a speculative theory, but it's another area of interest.
Once inside your body, the virus comes in contact with cells in your throat, nose, or lungs. One spike on the virus inserts into a receptor molecule on your healthy cell membrane like a key in a lock. This action allows the virus to get inside your cell.
So in this video, we could see how it's using the ACE2 receptor to infect epithelial cells in the respiratory tract. These receptors, ACE2 receptors and cells with them also exist in the kidneys, in much of the gastrointestinal tract, in many areas, possibly also in the ovaries and in the testes. So it's certainly an interesting area that is being researched right now. Some of this research is happening in India. As we can see in this graphic, the virus primarily enters through the respiratory tract. The initial symptoms are fever, cough, breathlessness, possibly a sore throat. For some, the virus is defeated in the upper respiratory tract. For others, it manages to infect the lower respiratory tract. And this is when we can really start to see problems. What we see is either thromboembolism or ARDS, where the alveoli start to get inflamed, and this leads to problems. So what are some of the risk factors? Who is really at risk of severe COVID? Although young, healthy individuals can also have severe disease, the vast majority of severe COVID and mortality and fatalities have occurred in diabetics, hypertensives, those with cardiovascular disease, chronic lung conditions, cancer, kidney and liver disease can also predispose, smoking, obesity, and immunocompromised status. And then older age groups, especially 65 plus, have had increased risk. Below 18s have had very low risk so far of what we know. And women seem to be at a lower risk than men. There are some interesting theories about why some of these diseases can actually cause upregulations of the ACE2 receptors. Many of these conditions like diabetes, hypertension, heart disease, smoking can damage the blood vessels. Damaged blood vessels are more susceptible to the damage caused by the virus itself. So interesting theories about why this happens. There are some theories that women have a slight protective effect because of estrogen and the X chromosome, which plays a very important role in the immune system. In the chart, we can see the highest number of severe cases have happened in those with pre-existing illnesses. Also, the highest number of fatalities have been in the advanced age groups, unfortunately. These are the vulnerable populations that we need to protect. When we talk about the clinical features, I want to point out that the vast majority of cases are mild or asymptomatic. In fact, all the cases we have seen represent just the upper part of the pyramid. The vast majority of cases have gone unseen and undetected. So that's something to consider. A lot of people will not have very severe disease, but because of the volume, the quantum of people who will get infected, even the small percentage that are severe cases or critical or that have terminal outcomes represent a very large absolute number. So the main clinical features, cough, which is usually dry. Occasionally there can be sputum or hemoptysis, fever, commonly with chills. Up to 50% of patients may not have fever at presentation, but the ones who do get hospitalized, eventually 80 to 90% do develop fever. The breathlessness has been interesting because we're seeing something called silent hypoxia, where patients develop hypoxia, but they don't necessarily get aware of it. So they continue with their activities, and it's shocking because when we examine them, we see that they're on pulse oximetry, their saturation levels can be below 80, but the patient is like looking at their phone, conversing with you, doesn't seem very breathless. Myalgia, fatigue, tiredness, some gastrointestinal symptoms. Sneezing, rhinorrhea, and nasal congestion have occurred, but they are rare. New studies have shown that very early on, anosmia and ageusia, so the loss of the sense of smell and taste, can actually be discriminating clues for COVID. Tachycardia, tachypnea, hypoxia, these are things we should look for. Auscultation can be normal. So you may not hear abnormal chest sounds on auscultation. In the patients who are symptomatic, mildly symptomatic, they can recover completely in up to 2 weeks. The ones who have severe disease may take 3 to 6 weeks to recover. And unfortunately, over 50% of those who are critical don't make it. So just another graphic about the symptomology. We can see the distribution. So fever, cough, fatigue, these are some of the more common symptoms. And you can see that some of the gastrointestinal symptoms are not so common.
As your immune system attacks the multiplying viruses. The inflammation can cause your alveoli to fill with fluid, making it difficult for your body to get the oxygen it needs. You could develop lobar pneumonia, where one lobe of your lungs is affected, or you could have bronchopneumonia that affects many areas of both lungs. Pneumonia may cause difficulty breathing, chest pain, coughing, fever and chills, confusion, headache, muscle pain, and fatigue. It can also lead to more serious complications. Respiratory failure occurs.
So we could see in this graphic the kind of symptomology that occurs and how it happens. As we saw in one of the prior slides, part of the damage can be the effects of the infection itself. Part of it can be because of thromboemboli. And then another part is because of the immune system. The immune system can be misdirected and start attacking the body. What are some of the complications that we see? So mild cases can progress to severe cases with complications over a period as short as 7 days. The median duration of onset of ARDS after symptomatic onset, after symptoms start, is about 8 days. Pulmonary emboli can occur anytime in hospitalized patients and critical patients. We are seeing a fair amount of acute kidney injury, hepatitis, myocarditis, myocardial injury. Some evidence is showing neuroinvasion, that the virus may be able to invade the optic nerve, the olfactory bulb, and then transmit to the brain, cause seizures, altered sensorium, headache, vomiting. We are seeing strokes. Most of them have occurred in individuals with pre-existing illnesses, but alarmingly, some young, healthy individuals have also had strokes. A small case series is starting to show GBS is developing, typically about 10 to 14 days, 10 days after onset of symptoms. A very small case series, so we're not sure whether this is coincidence or causality, but it's interesting. We're also seeing something called post-intensive care syndrome. We see this in many critical illnesses. Just the period that patients are in the ICU for can cause this. Unfortunately, patients and their relatives are also developing PTSD. Another graphic I want to show you of what happens to the lungs in ARDS. The panel on the above is showing the airspace changes, and the panel below is showing the vascular changes. And on the left, we have ARDS lungs, and on the right, we have healthy lungs. So you can see the drastic change in ARDS in both the airspace and the vasculature. And some evidence is suggesting that it might be more of a vascular process than necessarily an airspace process. And other evidence is suggesting that there are diverse subgroups of patients. Some have either one of these, some have both. Going into the laboratory findings, so we can broadly divide these into diagnostic tests and ancillary tests. So the gold standard right now is the real-time reverse transcriptase polymerase chain reaction, RT-PCR. It's quantitative, so it doesn't just give us a positive or negative, it can also tell us what the level of viremia is. It's very sensitive and specific. However, different samples have different levels of sensitivity. So samples from the upper respiratory tract have poorer sensitivity than samples from the lower respiratory tract. Nasopharyngeal swabs are better than oropharyngeal swabs. Some recent evidence is saying that salivary swabs might be very good. We can also test feces. Importantly, a positive test can be diagnostic, but a negative test does not rule out infection. So there have been cases where, there have been patients who've been tested 4 or 5 times and they're negative. So use your clinical judgment. That's your best diagnostic tool. If a patient tests negative, you might need to repeat the test several times if your clinical judgment makes you believe it's COVID. Antibody tests, there are broadly 2 kinds. The laboratory tests are pretty accurate. Unfortunately, they're not widely available in India yet. The market has been flooded by rapid tests. All the data we have on them is manufacturer data. So, people claim they're very sensitive, they're very specific. But what I have been seeing is that 1 out of 2 or 1 out of 3 patients get a result that just doesn't make sense. The IgM can be negative very early on, whereas the IgG is positive. Some patients who have clearly recovered have a positive IgM and a negative IgG. So, some patients who should have positive antibodies don't. So take these tests with a bit of skepticism. Importantly, ICMR and WHO both have clearly said these tests should not be used for clinical decisions. They are only meant for research purposes and serosurveillance studies. They also have a window period, which I'll come to a little later. The antigen tests, so, like we do the rapid test for dengue, we have an NS1 test and then the IgM, IgG. So like that, there are, like the NS1 antigen test, there are people working on antigen tests for COVID. Sensitivity might be an issue, but this is interesting. I don't think I have time to get into this graphic here, but it basically explains which test is best used in which purpose. This graphic explains the window period. So you can see that early in the infection, the IgM, IgG may not even be positive. So, up to 9 to 12 days, you may not see a positive IgM response. So this is a little important and explains the importance of the PCR assay. Here you can see the technique of how the swab is to be collected. I myself was swabbed because, I was exposed and then developed some mild symptoms. Fortunately, was negative. You can see that the swab really has to be inserted quite deep, and a failure to do so gives you a nasal swab, not a nasopharyngeal swab. So you have to feel the resistance at the back. It's quite a dangerous process collecting these swabs. I used to do these fairly routinely for H1N1, and you get sneezed on, coughed on. Sometimes if you're particularly unlucky while taking the OP swab, you can be vomited on. So, you have to take sensible precautions. What are the ancillary tests? So imaging, CT chest has proved to be a good diagnostic tool in terms of sensitivity. However, it has a low specificity. You can't really differentiate between influenza and other respiratory pathogens. There's a huge infection risk to the patients and the personnel. Artificial intelligence is beginning to augment these modalities. Typically, we see a ground glass opacity kind of picture, bilateral changes, they're subpleural, peripheral, more in the lower lobes. Imaging is not recommended for routine diagnostic purposes. The CBC frequently shows lymphopenia. Inflammatory markers like CRP, ESR, and ferritin are elevated. Creatinine, liver enzymes can be elevated. The D dimer can be elevated, indicating potential risk of thrombotic complications. In terms of the management, we first need to decide the site of care. So asymptomatic and mild cases should be and can be managed at home, provided they can take adequate precautions to prevent infection of people living with them or their neighbors. Severe breathlessness. Anyone presenting with breathlessness, you need to watch these patients very closely. The WHO says up to 20% can require hospitalization. But as we saw, we're only seeing like the upper half of the pyramid. So this number is actually probably quite lower. Similarly, they say up to 5% can need ICU. But like I said, this number is probably lower. The most important thing in managing COVID-19 is universal infection control practices. This means that you have to do them all the time with every patient. They're universal. Assume this is everywhere. The main treatment measures are supportive, so control the symptoms, fever, cough, pain, oxygen therapy. Prone position care really does help. So case reports out of New York and patients in Mumbai, so showing when you put patients in the prone position, their oxygenation can really improve even with just oxygen therapy. Really important to prevent dehydration. Manage any comorbidities like diabetes, hypertension, manage co-infections if they occur, monitor for the development of complications. Low molecular weight heparins, they're proving to be very effective in preventing VT. Anyway, critical care patients in medical ICUs get low molecular weight heparins. So if there aren't contraindications, we should use them. Patients who require ventilation have a poor prognosis. In some case series, up to 70 to 80% of patients who have gone onto ventilators have not made it. Before we get into specific treatments, a little disclaimer. This is a little cartoon, and what it says is when you see a claim that a common drug or vitamin kills COVID in a Petri dish, kills the virus in a Petri dish, keep in mind, so does a handgun. So, it just tells you a lot of the studies we have right now are based on very, very early information. They're based on laboratory studies. They're not randomized control studies. We don't know how effective these medications will be in humans. And that's important. We need to know what the harms are. We need to know what the benefits are. So RCTs are the need of the hour. The antivirals, so none of these treatments are proven, but recently remdesivir, it's an antiviral that acts on viral RNA-dependent RNA polymerase. It is now, in the US at least, considered standard of care. Some anti-HIV drugs, antiretroviral therapy, seemed promising, but the few trials that have been conducted so far show that there's no benefit, and many patients have to stop taking them because of side effects. Favipiravir is a antiviral used in influenza. In Japan, it was showing some benefit. EK1C4, it's looking like a miracle drug in laboratory studies. That's actually why I've put this little cartoon up. In a laboratory study in mice, it not only treated 100% of the mice, more importantly, it prevented infection. This, unlike remdesivir, which is administered IV, EK1C4 can be administered as a nasal spray or as an inhalation. So that means you don't need to give it in a hospital. It could potentially be given anywhere in the community setting. The other amazing thing about this, it's a pan-CoV class fusion inhibitor. So not only does it work on SARS-CoV-2, but it works on MERS-CoV, SARS-CoV-1, and even the common cold coronaviruses. All of this is laboratory information, but it's certainly an exciting development as far as antivirals go. In the immunomodulatory agents, the anti-IL-6 agents, tocilizumab has been promising. Clinical trials are awaited, but multiple hospitals across the world, and what we're seeing here in Mumbai, are that in a single dose, patients who are in the ICU 2 or 3 days later, they're much better. They're coming off ventilators. Sometimes you need to give a second dose. There are some concerns related to increased chance of infection, but again, exciting area. Convalescent plasma therapy. So just a disclaimer here. I'm just a conflict of interest disclaimer. I am a co-investigator on a convalescent plasma trial, so keep that in mind. But I do believe it's a very promising therapy. Of course, we do need clinical trials, but so far it seems promising what we're seeing in the rest of the world. We're just about to start our clinical trial in Mumbai. Monoclonal antibodies, again, promising. They're in the research phase. Many miscellaneous medications like hydroxychloroquine, chloroquine, azithromycin, ivermectin, nitazoxanide have shown promise in the laboratory setting. There is no evidence that these work based on any clinical data. And there are some studies that actually show hydroxychloroquine and azithromycin have caused increased mortality compared to placebo. Recombinant human ACE2. So it's administered IV. It's considered a rescue treatment. It has been promising. It's not very scalable, but it is something that can prevent the virus from infecting cells that have ACE2. It sort of traps them, and it can have a protective effect in the lungs. The other important thing we need to remember is that we aren't going to be able to serve all our patients, but we have to, we're not going to be able to save everybody, but we need to be able to serve everybody. So palliative care is going to be, it's a sad thing, but palliative care is going to be really important. A lot of patients are going to die, and we need to make sure that they're pain-free, they're comfortable, they're not anxious, they're going to be in isolation. So we need to use technology to make sure they have a fair chance to say goodbye to their families. These are difficult conversations and difficult things to think about. Doctors need to start thinking about them. Most of us have never had to deal with something like this. Staying safe. These precautions are universal. The important thing, as Sir pointed out in his presentation, is minimize exposure. The first and most important thing before everything else, before PPE, minimize exposure. Use telemedicine. Ask your patients who are going to come to you about symptoms. No relatives, unnecessary relatives not to be allowed. Make the patients wear a mask or a cloth covering. I will make available a guide from the CDC that explains to patients how to make a simple and effective cloth covering at home. limit the numbers in your practice. So no unnecessary personnel. Try to manage without your secretary. Try to manage without any additional staff. Keep like your residents or juniors out if possible, or let them manage. Limit the number of patients in there at any time. So don't make sure there's adequate distancing between the patients. Isolate any suspect. So keep a room or an area in your clinic where if anyone shows up who has a cough, is in your clinic, just put them in that room. Activate infection control procedures right away. Hand hygiene, so important, so important. Single most important thing. Wash your hands, follow the right method. The WHO has a great video. Start humming a song if you need to make sure you're doing all the steps. Respiratory hygiene. Make sure everyone is aware that they need to cough into the fold of their elbow, coughing like this into your hands, or coughing into a cloth like this. It just creates a fomite, or my hands are going to contaminate multiple objects. Use the fold of your elbow or use a tissue and throw it away. Do not touch your face. So I wear glasses. What happens frequently is when I'm at work, I don't wear them. I just manage without them, because if you have to keep adjusting your glasses, that's another face touch. If you have to use your glasses, don't use contacts. If you have to use your glasses, tape your glasses on. So put a piece of scotch tape on the sides and tape them on so you don't need to adjust them through the day. And absolutely just get out of the habit of touching your face. So lipsticks, cosmetics, all of that stuff needs to go. Engineering solutions are really important. So build physical barriers. I'll come to what my company is doing about that. But build physical barriers, put in curtains, negative pressure, like use air handling units. Infection control and disinfection protocols need to be very strong. All fomites need to go. So if you wear rings, watches, bangles, religious items, Mangal Sutras, mobile phones, pens, all of that needs to go. Ties, bow ties, all of that needs to go. We need to adopt to a completely new way of dressing. We need to stop carrying potential fomites in with us, like keys, car keys, etc. Just don't take those into work with you. There's no reason for them to be there. Next question is, are you at high risk? Are you elderly? Do you have diabetes? Do you have hypertension, heart disease? If you do, you need to strongly consider staying at home for some time. All of y'all are our teachers, our respected elders. Let the young generation like me take the risk right now. You can guide us using telemedicine. Protect your families. When you get home, right at your door, there should be hand sanitizer, shoes off outside the door, socks off outside the door. Put them into a box where they can be disinfected. Sanitize your feet as soon as you're in through the door. All your items, phone, watch, every single item goes into a box kept at the area of your house at the opening at the door. All your clothes are off right there and then. Put them into a bag which is going to go straight in the laundry. Walk into the shower. First thing you do is just shower, change into clean clothes. You need to protect your family. Don't bring the infection home with you. This is a clinic we designed. It's called the Safer Clinic. The first one is being operationalized today. I'm not at Burley to operationalize this, so I could present today. But it's called the Safe Assessment, Fast and Effective Resolution Clinic. So as you can see, the red areas have positive pressure, so nothing infectious is getting in there. The lighter colored areas have negative pressure. So any patient that coughs, it's getting sucked straight into the negative pressure area and destroyed in the virus burners. And then there's a curtain to separate the patient area, give some privacy. The panel, you can see there's a complete separation between the examining physician and the patient. There are gloves, there's a stethoscope, a pulse oximeter, non-contact thermometers, and a two-way speaker system. So, you can implement, we're also building low-cost versions of these. So for primary health centers, but you can easily do something like this in your clinic. And all of our designs are open source. So, you can go onto our website, you can just pick whatever you like, and we're more than happy to guide you, or you can get someone else to do it for you. This is another product we designed for the BMC. We're proud to say that it's in all the COVID-19 government hospitals across Mumbai. And in many of the cases, we raised the money and donated these for free. A company called Trivector that supplies plasma air sterilizers, they actually donated a few units for free. Plasma air sterilizers, that keep the air clean. So a lot of people have contributed and helped us put these across. It's a kiosk system for testing. Again, the person testing doesn't get coughed on, sneezed on. This is my company. I want to show you another product we've designed, and this is completely free. So if you like it and you want to integrate it into your practice, there's no charge. We're very happy for you to use it. What this does is it's an automated way of screening patients and triaging them. So you could roll this into your practice before you take an appointment. I'm just going to start this video. You can see it's basically like asking patients about their symptoms. So are they feeling sick? Are they exposed? When you select gender, it asks if the patient is pregnant, asks them how sick they feel. It asks for life-threatening symptoms. So anyone who has these life-threatening symptoms, they just need like an ambulance, it's an emergency. Then it asks for symptoms that might be an urgent situation. So for example, if you select coughing up blood, it will immediately tell you this is, you need urgent medical attention and not to wait for an appointment. If there are none of these symptoms, then it starts asking about fever, breathlessness, things like that. So, you get a very good idea, and this is going to be in multiple languages as well. So you get a very good idea of the patients that are coming into your clinic. Are they symptomatic? Are they safe for your clinic? Of course, asymptomatic patients can also be infectious, but this is an attempt. So you can see we're asking about a whole litany of symptoms. So, you have all this information before you take an appointment. Before we dip into protective equipment, I'm sorry I've shot so much over my time. I'll try to be quick through these parts. Before any of this, you can see in the hierarchy of infection control, PPE is last. It's the least effective. The most important is eliminate the source of infection, then substitution, then engineering controls, then administrative controls. So, you first have to prevent, source control is the most important thing. And PPE is the least important thing. So yes, of course, use PPE, but do everything else also. What is the PPE you need? You need a face shield or goggles, an N95. So in this graphic, you can see what the ideal PPE is. An N95 or higher respirator. If you don't have that, then a surgical mask will have to do. Non-sterile single-use gloves, a gown. All of these have to be used in an OPD setting as well. So please procure these for yourselves. If you need help, please reach out. We try to get people connected with the best and lowest, most cost-effective PPE manufacturers. The WHO recommends surgical masks for OPDs, but I would recommend using an N95 in your OPD setting. You don't need the N95 outside a healthcare setting, but in an OPD setting, I would use an N95. Most important thing, fit test, okay? You cannot use an N95 just like that. You have to make sure that the size you're using, it fits you. Every time you put it on, you have to make sure that there's no air leakage. There are great videos for this by the CDC. Please watch them, understand what a fit test is, make sure you have the right kind of mask, and make sure you're using the right technique to put it on. So just to explain, I think this will be shared with everyone, but just to briefly explain the different kinds of masks, surgical, N95, and elastometric. So the basic difference is that surgical and N95 are ideally single use, whereas the elastometric are multiple use. The N95 can also theoretically be used 3 or 4 times. AIMS has a protocol for this, the All India Institute of Medical Sciences in Delhi. They have a great video on how to repurpose the masks. The surgical masks aren't as effective, obviously, as N95, and elastometric are more effective even than the N95. If you can invest in an elastometric and you can invest in the processes required to disinfect it, that's a great option. When you buy an N95, there are a few things to look out for. The first thing is you want to look for NIOSH. So look at the NIOSH logo. Make sure it's not misspelled. Then you see the approval number. It says TC approval number. you can actually go onto the CDC website. You can enter that approval number, and the CDC has a tool that will tell you whether this is a real mask or it's a fake mask. So before you buy any N95s, please take some time to follow this process to make sure you aren't getting fake materials. Unfortunately, there are a lot of fake N95s going around. 3 key factors to make sure the respirator is effective. First, I cannot stress this enough. You can have the best equipment. You need to use it correctly. You need to put it on correctly, and you need to wear it during the exposure period. Second, it must fit snugly. There can be no air leaks. One of the common things you'll notice while exhaling, if you can feel air whooshing out onto your eyes or fogging up your glasses, that means the mask doesn't have a proper fit. You put the mask on, put your hand above the mask and breathe out. If you can feel air leaking out of it, it's not properly fit. But watch the whole video on this. This is very important. And then it's the quality of the mask, right? The mask has to work as advertised. You can see the technique that you need to put the headbands on over. Make sure that you're following the right technique on putting it on. And make sure you tighten the noseband. Real quickly, how do you put on PPE? There's more than one technique. This requires training and supervision. We follow what's called a buddy process, where I watch my friend watches me. They make sure we're doing the right steps. So first, identify and gather all the PPE. Make sure it's the right size. Hand hygiene. So sanitize your hands. Put on the gown first. You may require help for tying it at the back. Then put on the mask, ideally an N95. Put on your eye protection, ideally a face shield. If you don't have a face shield, then goggles will do. After you've done this, perform hand hygiene. Wait for your hands to dry completely, air dry them. And then put on your gloves. The glove should cover the cuff of your gown. There's a little graphic. This is available on the CDC. And I believe my presentation will be made available to all. So you can look at the graphic on the sequence of putting on PPE. There are great videos on this as well. Doffing PPE, removing it. Again, more than one method. I really want to stress this. You need to follow your local hospital or government biomedical waste policies. It has to go into the correct bins. Don't just throw this PPE anywhere. Training and supervision is required. Buddy system again. Before you start removing anything, perform hand hygiene over your gloves. Remove the gown and the gloves together. Roll them into one. Perform hand hygiene. Remove your eye protection. When you're removing your eye protection, do not touch the front. Remove it from the back. Touch the band. Perform hand hygiene. Remove the mask. Again, use the band. Do not touch the front of the mask. It can have virus on it. Perform hand hygiene. And during each of these steps, dispose of the PPE correctly. How long is this going to last? That's the question of the hour that I think every clinician has. I believe COVID-19 is here to stay. This is a pandemic virus. It's going to keep going until 60 to 70% of the population has immunity, either due to recovering from infection or a vaccine. The pandemic may last anywhere from 1 to 1.5 years. Unfortunately, the timeline for billions of doses of vaccines to be available is also 12 to 18 months. Pandemics can have multiple waves, and the first wave is usually the mildest. So you can look at the 1918 Spanish flu pandemic, the graphic here. The first wave was the mildest wave. The second wave was terrible, was devastating. And then there was a third wave. So understand, if we have a second wave of COVID in India, it's going to hit us when malaria, dengue, all the monsoon-related tropical illnesses are peaking. If there's a third wave in the winter, it will hit us when there's seasonal influenza peaking. Pandemic viruses are less affected by changing weather. The infection fatality rate of this virus is about 10 to 20 times higher than seasonal flu, and it's going to infect a lot more people than influenza. So that's something to keep in mind. Like Sir pointed out earlier, this is the world of COVID now. We are in the COVID pandemic period. We must adopt a new way of life. Be vigilant, be careful, but don't panic. We are medical practitioners. We have to serve our patients. It is our duty at this time. We have survived pandemics before. Everyone who's alive today is alive because our ancestors survived a pandemic. The last thing I want to point out is the virus knows us better than we know it. There's very little we know about this virus. Nobody knows what's going to happen in the future. And people who claim to predict the future should have warned us about the pandemic, right? So I have some little amount of expertise on this subject, but I can't predict the future. I'd like to end with just a small mention of my website, www.diy.health. You can log on and most of this information will be there. All our plans of everything we build is put up for free for everyone to use. And the tool that I mentioned to screen patients symptomatically, it's available for free. Anyone can use it. We'd encourage everyone to use it. I just want to end with a thank you and a note and a quote from Karl Popper, a philosopher. Our knowledge can only be finite, while our ignorance must necessarily be infinite. And so is true of COVID. What we know of it is far less than what we do not know of it. Thank you so much for hearing me out. And I'm so sorry I went so much over my time. Thank you.
It was a wonderful talk, Swapnil. And I think so this happens, when the subject is known so much to you, the time flies. But I am 100% sure that 1200 plus people listening learned a lot of things. And apart from the question, we will maintain a link wherein our queries are solved by you. It was an excellent talk, covered almost most of the aspects. And we will just work out during the question answer session. The third speaker, obviously, she's the person who introduced me to ART, and Dr. Firuza Parekh, obviously, she's a wonderful genius, past president of ISAR. She's the director of Fertility, Jaslok International Fertility Center, editor-in-chief, Fertile Sterile Indian edition, editorial board member in Fertile Sterility USA. 15,000 plus couples have been benefited with having babies with her team. 200 plus scientific publication, 30 chapters, plenty of award. Their team were the first to bring PGT twins and BRCA mutation patient also. IVF team, which has consistently won the best IVF center award West Zone 2016, 17, 18. And one thing which I would like to tell from my side, she's a person who is meticulous, very friendly, deep in knowledge, has respect for everybody. She's straightforward. She will go head on any aspect, but in the heart, she's very soft. In knowledge, she is just impeccable. She will be talking about fertility during Corona time, and I'll request all the other people who to have their video and audio both shut off. Firuza.
Yeah.
Hi Prakash, thank you for your very kind
Good evening, my friends. Thank you, dear Prakash, for inviting me for this ISAR symposium. Thank you, Dr. Swapnil Parekh, for joining us. And thank you, Bharat Serums, for your educational involvement. The topic that I'm going to speak on today is fertility in the times of COVID-19. I think, given the current situation, it's going to be a very apt topic. Let me ask you, my friends, have you ever seen a peacock in South Bombay perched on a car? Well, this is what COVID-19 has brought us. This is Borivali National Park, where you see the deer freely roaming in the forest. Well, we are locked in and the animals are out. That is the nature of SARS-CoV-2. So now let's get into the heart of the matter. Here we'll be talking both of infertility and pregnancy and the impact of the coronavirus on this very vulnerable group of women. Both these situations cannot be classified as elective. These two groups need our special attention because I said this is a vulnerable population and some unique problems which need innovative solutions are posed in this population. We have to consider the pregnant woman, her partner, their baby, the immediate and extended family, the mode of delivery, breastfeeding, the caretakers, and society at large. Let's also look at some aspects of the oocyte, the sperm, the embryos, the infertile couple, the biological clock, ART procedures, the fetus, the baby, the partner, general conditions, what is testing in this situation, the emotional and the reproductive cost of aging. A question to you, my friends. In this battle against SARS-CoV-2, are women better equipped? If there is time, we may touch upon this a little later. Now, these are two slides which tell us the effect of age and pausing fertility treatment and how it would affect outcomes. The first slide is a very old slide of 1986, and it shows that as the female population ages, the fertility rates come down. This is a more recent paper, and here two groups of women are compared. Those who have used their own eggs and those who have used donor eggs. And you can see that with their own eggs, or as their age increases, the fertility decreases. Whereas with donor eggs, it practically remains the same. There is not only a systemic and physical impact of this virus, but there is a very big emotional toll that this is taking and will take on infertile couples. In fact, all of us have been faced with a situation where couples have come to us from thousands of miles, hundreds of miles away, and we have to turn them down because of this sudden pandemic. We've had emotional bursts. We've had tears from patients' husbands saying that how could we give up on the treatment and when will we start? We get frantic phone calls begging us to start. But friends, we are not ready. We have not flattened our curve enough to start infertility treatment. There are many strong bodies like ASRM, ESHRE, which has given guidance to all the doctors who are practicing reproductive endocrinology globally. As soon as this epidemic became a pandemic and people realized that this is going to impact on reproductive care, the ASRM gave out its guidance on 17th March. The guidelines were quite clear. They said one should suspend initiation of new treatment cycles, including ovulation induction, intrauterine insemination, IVF, including retrievals and frozen embryo transfers, as well as non-urgent gamete cryopreservation. It advised or it guided saying that we should strongly consider cancellation of all embryo transfers, whether fresh or frozen. However, one should continue caring for patients who were in cycle or who needed oocyte or embryo cryopreservation in view of the toxic therapy being used or gonadotoxic therapy in cases of chemotherapy. As soon as this guidance was given, a group of 400 fertility specialists called Fertility Providers Alliance wrote out a letter to the CEO of ASRM, Ricardo Aziz, and criticized this guidance because there was very little input that was sought from the providers of fertility care. Many of these centers in USA and all over the world, including in India, are freestanding medical facilities, and many of these operate without any hospital affiliation. They describe themselves as not doing business as usual and stressed very much that infertility is a disease and therefore requires a cure. The ASRM recommendations were revisited and reaffirmed on 30th March and 13th April, probably saying the same thing: suspend elective surgeries and non-urgent diagnostic procedures, minimize in-person interactions, and increase the utilization of telemedicine. And the task force was formed at this point to draft recommendations on strategies for prioritizing and resuming infertility treatment in the weeks ahead. So, the ASRM gave us a rationale, and they said that whatever guidance was given was aimed at guarding the health and safety of patients. It was the social responsibility of the ASRM as an organization consisting of healthcare providers, experts, to comply with whatever was the national public health recommendations and therefore apply these to all the reproductive settings during these unprecedented times. They were also trying to proactively do their bit in blunting the impact of this pandemic and recognizing the need to safeguard the limited health infrastructure and resources that were present at that time. Many patients were angry, disappointed, furious, and helpless. 20,000 signatures went to ASRM, and they said they were stunned by these guidelines, which meant there was an essential shutdown of all fertility treatment. Everybody felt that fertility treatment was both necessary and time sensitive. And different parts of the country were seeing this pandemic at different points in time, and therefore it may be prudent to start opening up centers prudently as the curve got flattened. So there was an update on this guidance on 24th of April. This is what the task force said. In view of the fact that there was flattening of the curve in some places, and also because COVID-19 was here to stay with us for a long time, there had to be strategies in place to mitigate the disease in the community, and also the task force recognized that fertility care is very essential to the health of the community and a delay in treatment could impact on fertility rates. So the task force made a very detailed document to guide the IVF specialists. So to summarize, what ASRM said was that national, region, and municipal regulations have to be followed. Clinicians need to be flexible on the way forward and recognize the risks of the community and the resources that are available when starting the clinical activities once again. There has to be a sustained reduction in cases in the area over 14 days before one can start. And it was very important to protect patients, staff, physicians, and healthcare providers. In this point, one had to look at education, training, and risk assessment. However, it would remain on the clinics to decide what treatment was to be resumed, to consider limiting number of services and
I think so. It is the video is static. Seshan, can we get an idea? Just 2 minutes.
Just give us 2 minutes, doctor. We'll just sort this. There's some technical problem.
Effect of COVID-19 on pregnancy and maternal and fetal risks. Counseling, therefore, is extremely important. Before starting, I would advise you all to have all your SOPs in place, have procedures to protect your staff, and be familiar with local and government policies because these are likely to change from time to time. There has to be policies in the clinic and in your setup on physical distancing, the use of masks, decontamination, cleaning, hand washing, what tests to be used at what time, what are the warnings given by the FDA, by the Government of India, by the ICMR, by your local municipal councils. And also it's important to know the immunity of your staff, who is safe, who can work, who has antibodies, who has suffered from COVID-19 and who is vulnerable. So one has to put a lot of precautions in place, looking at PPE, how to preserve PPE, what type of PPE one will wear, whether one can work from home. Working in shifts is a good idea. It's important to decrease clinic visits. Counseling is important. One needs to spread out appointments, and telemedicine is the medicine of the future, as we know. So I think it would be safe to start when we flatten the curve and when we bring the R naught to 0 or to 1 or less than 1. I've already gone through all the pros and the concerns and the safety of the staff. The one key point that one needs to keep in mind is to follow the local considerations of your community, of your area. And think of starting when you have all your procedures, all your SOPs in place, and when you feel that you are not putting a burden on the healthcare system. Now, let us go through some of the scientific literature that is emerging and which is going to help us to determine, are the sperm going to be safe? Are men going to be safe? Are the eggs safe? Are the embryos safe in this very trying time? So now, let's look at whether SARS-CoV-2 is likely to affect oocytes, embryos, sperm, testes. There is a paucity of literature on this, but there's a very interesting paper by none other than our Deepak Modi from GnRH, who has shown that there could be an involvement of embryos with the SARS-CoV-2. What he showed was that early human embryos have the receptors ACE2, and they also have the ability for viral spike protein priming, and therefore their results showed that developing human embryos can express these receptors and can also harbor the necessary machinery for viral replication. Therefore, their group suggested that couples should avoid conceiving during this pandemic. However, this is one paper, and there has to be much more literature, much more data coming out to support this theory. This is a nice cartoon given by Deepak where he shows how the virus enters the system. And here, this is a lock and key mechanism by which the SARS-CoV-2 virus sits on the ACE2 receptor, gets primed, enters the cell, and then gets activated and replicates. This is a very nice diagram again by Deepak showing us the presence of these receptors and the S protein activation enzymes which will prime the virus to enter the cell. There are actually two papers I want to discuss over here. There is a recent paper which came in Fertility and Sterile of April 2020 where they showed that there was no evidence of this virus in the semen of males recovering from COVID-19. However, this was a study of about 34 adult Chinese males who were diagnosed with COVID-19, and what they did was the semen was collected over a long period of time, and they showed that the virus was not detected in the semen after a median of 31 days. However, by this time it was possible that the virus had stopped secreting in the semen. And although they said that there was no detection of the virus, and also they suggested that there was no ACE2 receptor in the human testicle, there is another paper which I would like to draw your attention to, and this was presented in the same month of April 2020, where Wang and Zhu showed that there was a presence of the ACE2 receptor within the testes, and this could become a target for infection in spermatogonia, Leydig and Sertoli cells. So these are two contrary papers, but again, not enough for us to define whether the testes will be a target for this virus. However, in the previous paper of the Chinese study, many of these men had painful testes during the time of the COVID-19 infection, suggesting there was some inflammation within the testes. Let's quickly and briefly touch upon another paper, again by Modi's group, which shows the complications that can occur in pregnant women. A very important part of this paper was also showing that there was a vertical transmission rate of about 11%. This was a systematic review where they looked at 172 women and the complications that occur. Many of these women had fever, cough, dyspnea, diarrhea. Pneumonia was diagnosed in 100% of these COVID-19 pregnant women with a CT scan, and the pregnancy complications included preterm labor, fetal distress, and premature rupture of membranes. There was a very high rate of cesarean section, almost 90%, as compared to vaginal delivery. There were many comorbidities, and this can put these pregnant women to be more vulnerable to COVID-19, and these were diabetes, high blood pressure, co-infection, scarring of the uterus, hypothyroidism, and anemia. There were some women who were subjected to significant morbidity. The newborns had preterm birth, respiratory distress syndrome, low birth weight, and 3% were small for gestational age. There was one stillbirth and one neonatal death. The thing to look at in this paper is the mother-to-child vertical transmission happened in 11% of these babies. So although initial data showed that there's no vertical transmission, this paper shows an 11% rate of vertical transmission. There are certain guidelines given by ESHRE, and there are 6 main pillars of this guideline. This include discussion, agreement and consent, triaging the staff and the patient, access to advice, adaptation of the ART services, how to plan the treatment, and the code of conduct to be carried out by the staff and the patients. Again, as I told you, telemedicine in the times of coronavirus is here to stay, and all of us will have to become competent with telemedicine. This is just a diagram showing you how to triage a patient and how to take them through with oocyte retrieval and embryo transfer once we start. It's very important to plan the treatment cycle to understand what is going to be required of the doctor, what is going to be required of the staff, and what will the patient have to comply with in order to carry forward the IVF cycle. There are many things we'll have to follow at the time of oocyte retrieval, including sanitization of the IVF lab, the operation theatre, the PPE. It's very important for us to prepare ourselves for donning and doffing of the PPE. It's not as easy as one thinks. One needs to try out the PPE several times before actually starting oocyte retrievals, and there is an entire process involved in disinfecting the operation theatres, the embryo transfer room, and the IVF laboratory. Again, good laboratory practices are to be followed. The staff has to be organized in mini teams. Extra care has to be taken to reduce exposure of the embryologist to the follicular fluid and the sperm, and all the SOPs have to be in place before we start any laboratory procedure. I think most of us are going to go for freeze-all policy in the near future when we start. It's important not to expose too many people to the patient and the patient to the staff when doing embryo transfer. Also, it's very important to have mini teams. So, in our setup, what we plan to do is to have team A, team B, and team C, and delegate them at different times of the week and have one team for 1 week, team B for the second week, and team C as a standby. So I love this picture because, before COVID, there was complete chaos in many IVF clinics. And today, we'll have to practice physical distancing, and just see the difference in these two pictures. All this is summarized by these pictures. There's a very nice lecture or lectures given by people from VitroLife, and what they summarized is we have to have a plan in place before we reopen. We have to look at our staff, we have to look at our inventory, look at our cryopreservation protocols, and lot of thought will have to go into how we are going to conduct ourselves when we start a program. It's very important to maintain inventory. Once we start, we'll have to have a lot of media. We'll have to have different media for freezing, for thawing, and we'll have to have supplies coming in. It cannot happen that suddenly we face a shortage and therefore cannot do freezing. So we'll have to have an act in place. We'll have to reconfigure our staff, and this is the typical day in the lab when everybody is close together and one hopes that we can have physical distancing, but how many of us will have the luxury of big spaces? To end my talk, I would like to say sharing in these days is not caring. We'll have to limit the number of staff. We'll have to stop sharing computers. We'll have to stop sharing pens. We'll have to limit the use of shared phones. We'll have to do a thorough cleaning up at the end of the day. But let me end by saying, let's not share things in the lab and in the OT. Please do share your hearts, your minds, and your compassion. We are as safe as our weakest link. Thank you, dear friends, for your patient hearing. This is a picture of Apollo Bandar, the gateway of India, on a Sunday afternoon in the times of COVID. This is a very, very congested area which doesn't have any people in these times. I would like to share with you a wonderful book which has been written by Dr. Rajesh Parekh, Dr. Swapnil Parekh, and Mahira Desai on the coronavirus. You can download it as an e-book and it is available on the internet. My journey and my education in this field started with these three people authoring the book. Thank you again for your patient hearing.
Thank you very much, Firuza. I am sure everybody is planning bound because all the three talks were important. Incidentally, we do have 1600 plus people joined in. We have the ASRM, ESHRI, ISAR thing to start, but I'll remain fair to this webinar and we will move to the questions. I hope Swapnil and Firuza and all are around. Firuza, wonderful talk as usual. And Swapnil, it was fantastic. We are having 1600 people and we'll go ahead with the questions. I will answer my questions a little later on. There's one question to Swapnil. When a patient is ready to receive plasma donation after active infection, Dr. Manisha? I have this answer, but Swapnil, you have to give the answer.
So the reality is that this is a clinical trial right now. It's not a therapeutic application. So in the clinical trial, when the patient who is moderately ill meets our inclusion and exclusion criteria, then we will give the plasma therapy. But as of now in India, it is not available for use outside that setting. And as of now in India, the ICMR's clinical trial is reserving it for moderately ill patients.
Yeah, I do believe some movie star and the girlfriend had got and they were ready to donate their plasma if it is needed. The other question is, you mentioned, of course, we all are aware about post-ICU problems. So somebody has asked, okay, what do you mean by post-ICU problems?
So typically, not all patients, but some patients who have prolonged periods of ICU admission, especially when they are on ventilators and given agents that paralyze them and knock them out, they can have mental effects, cognitive effects, and physical effects. So the physical effects can be motor incoordination, muscular weakness, ataxia, loss of muscle mass, atrophy of muscles, disuse atrophy. The cognitive effects can, be memory loss, difficulties in executive function, mood disorders can happen, depression, anxiety, PTSD. So that's typically what we see. Most patients recover, but some can take a very long time to recover.
Before I go to Firuza, whether EK1C4 is available in India or not available?
Like I said, EK1C4 should be thought of a handgun pointed at a petri dish at this point. It's just exciting news based on laboratory studies. It is not available for human use anywhere in the world right now. We have no idea how it will perform for human use. It's something that looks promising in a petri dish. Let's qualify it and leave it at that.
Firuza, there are concerns about liquid nitrogen. Can you elaborate on how to handle refilling, etc., related to liquid nitrogen?
Yeah, Prakash. So there are two concerns. The first concern is that will we have a steady supply of liquid nitrogen? I know that when the lockdown was declared, all of us were in a panic because we wanted to make sure that the canisters were well filled. Now, for those of us who have the setup of an alerting system with an alarm, which can be accessed from your home, it will have tremendous benefit because it will allow you to know what are the levels of liquid nitrogen. There must be remote access to everything now in the lab. And that is where your telehealth, telemedicine, remote control will come in. We need to be very, very aware of failure of systems because of this pandemic. We have to make sure our generators are functioning. We have to make sure that we have a constant supply of liquid nitrogen. Now, when we start, it will be very important for us to designate some containers which will not be mixed, the liquid nitrogen cryo tanks, which will not be mixed with tanks which we have used before. And therefore, I would advise all of you, all of us, to please order extra tanks with a large space so that we are careful in putting suspect cases where we are not sure in those containers. There is something called vapor technology, liquid nitrogen. I don't know too much about it right now. I'm looking at it and whether that technology can be used, because there is a worry that liquid nitrogen as such may cause a cross-contamination. So people are suggesting that we use vapor technology. I'll read a bit more on this. I'll see how we can have access to this and then perhaps offer some suggestions.
Another question is whether COVID testing should be done before starting an IVF for an oncology patient in a case for fertility preservation.
Yes. So, Swapnil, I may request you also to add on something to it. Did you hear the question?
I'm sorry.
Yeah. So, Prakash, would you like to just repeat it?
Would you do a COVID testing before starting IVF for an oncology patient in a case of fertility preservation?
Correct. So there are certain caveats in this which I would like to bring about. One is oncology patients have to be time bound. We have to see that we can offer them successful freezing. And you know, these rules are changing day to day. At our hospital in Jaslok, we had to wait on doing oncology cases and doing stem cell transplants and doing chemotherapy because at one point testing was not available for everybody. There was shortage of kits. Now the plan that we have made at our hospital is to test patients undergoing chemotherapy once a week. So obviously any procedure which requires an intervention will need to have testing done. Sometimes there will be cases where the patient being immunocompromised may present with COVID, and these are the very critical cases that we will have to decide on a custom-based, there'll be a custom-made answer. So there is not one answer that I can give for all patients put together. So, Swapnil, in case you want to add something.
What I would say is that, our best asset as doctors is our clinical judgment. It's very difficult and it really slows the process down if some centralized body is mandating that doctors operate in a specific way as a broad guideline, because patients are very different. I mean, different patients need different things. And I feel the best judge of that is the clinician, like people who have experience and expertise for a long period. They are the best judge of what their patient needs. Of course, follow broad guidelines. So someone who's not at risk and asymptomatic, don't waste a test on them. Keep it for people who need it. We have very few kits. But someone who's at high risk, potentially could have symptoms that are, COVID, then I think the clinician is the best judge. The treating doctor is the best judge in that scenario. And we should enable them to make those decisions.
Yeah. There's one question. There are plenty of people from abroad who are on the webinar. And one person, Firoza also knows, and I also know her very well, Dr. Anu Chawla from UK. She's asked that if a patient comes with a history recovered from COVID infection, what is your advice for treating and directions for staff in this case, and for such a patient, what they should do and what should that staff do?
Swapnil, would you like to take that? It's more in your field.
Yeah.
So we would need to firstly define what the recovery is. There are specific criteria that have been set by the CDC, which there are multiple permutations and combinations based on how many times the patient has been swabbed, how long back they developed symptoms. That's available on the CDC website. But in India, what we follow is that if a patient has had 2 negative swabs, consecutive negative swabs, 24 hours apart, and they have recovered symptomatically, then they are not considered infectious. So I don't think we should stigmatize people who've recovered. I would advise against that. People who have recovered, anyone, everybody, even people who are sick, everyone's a human being. We shouldn't stigmatize the sick people or the infected people. And certainly people who have recovered, evidence tells us they're not infectious. This evidence might change in the future. What we know right now is that they are recovered, not infectious. And we should treat them like everybody else.
Yeah. There are, of course, a lot of questions on endoscopy. I was intentionally keeping it silent. One from Manita Rathi is that if there is an ectopic pregnancy without testing COVID, asymptomatic means no fever, asymptomatic from COVID point of view, what we should do. I would actually like to address each and every person. Don't have imaginary panic for patients who are asymptomatic and obviously like a rupture uterus or like an ectopic which you're having as an emergency. You have to treat them as COVID positive, knowing very well that they may not be. But you can give them the benefits of laparoscopic surgery with fast recovery and keep a watch on her. She may be relieved of her ectopic, but you have to be relieved only afterwards when she doesn't have any symptoms and when there is a possibility of tests to be done. There are also repeated questions about how safe it is to use laparoscopy instrument in the COVID atmosphere. Now, there are two important aspects we have to remember. In any normal laparoscopy OT, the sterilization was always of premier importance. The major thing which has got changed now is the OT personnel and the OT equipment. Because Swapnil had mentioned about fomite or somebody's coughing and then things can be. So you have to understand the cleanliness in real sense means that you may have so many endomats, you may have insufflators, you may have monitors, this, that, etc. and all. And believe me, we have been many operation theaters, and Chris also will agree with me, when you touch something, you find a little bit of dust which is there, probably which can be old. So you have to be very particular before starting the surgery. Proper cleaning, proper fumigation, each and every equipment. I'm not even talking about the instrument. Each and every equipment have to be clearly swiped and washed. You have to use proper vacuum cleaner. You have to fumigate. You have to sterilize endoscopy instrument as you were doing earlier. More important than that is you see that the anesthetist takes due precaution, and you as a surgeon, assistant, and the pelvic person takes due precaution to see that we don't contribute anything and we neither get anything out of it. Now, the most important thing in a COVID patient after a laparoscopic surgery, as we told that the anesthetist may be taking out the tube, etc. and all, the most important instruction is you will go out, you will talk to the patients and the relatives, the sister and OT tech, we have a very senior OT tech. It is their job to immediately take care of all the instruments, equipment, wash it, clean it, dry it. All the necessary precaution has to be taken. It is not that you put it in some steady fluid and expect that everything will go away. So basically, emergency laparoscopy can be done. Elective laparoscopy, as I told you about New Orleans, we ourselves did 2 emergency laparoscopic hysterectomy where the patient had such big fibroids and they were not responding, and we took all the precautions. And I also showed you that 2 methods by which you can filter the suction and filter the gas. So you have to take that as a precautionary measure, because at the end of the day, you can't control the herd of patients. And when you're going to come back, and this is Swapnil, something very important. When we are going to come back, today is 2nd May, we'll be there again on 2nd August. So it is not that COVID is totally disappear from the situation. So there may be a different wave. So I think so life after COVID for next 6 to 10, 12 months will be same as what we are discussing today. Swapnil, what would you like to tell about that?
So I think you're absolutely right. We're medical practitioners. This is the oath we took to serve our patients. It is our duty. Of course, it is also our duty to stay safe, so we don't transmit the infection to our other patients, and so we stay, so our families don't fall sick. And of course, we should also not unnecessarily take risks. There are some innovative strategies that my organization has been looking at. So one of the things is, and Sir did mention this, is negative pressure. So you can have strategies where you strategically put negative pressure devices. And there are studies that have been done with smoke vapor. So if you place a negative pressure device close to the port entry, theoretically, any aerosols that are generated would be pulled into that negative pressure. We, for our safest cabin, Trivector, it's a company that imports these Novaris plasma sterilizers. They donated one of those to, in theory, how it works is it pulls the virus into it, and within milliseconds, it destroys it. So, devices like that are another potential thing, HEPA filtration systems. And then the third thing that is really low cost, and that's something we're actually working on right now, is it's a dome-shaped, single-use plastic device that, it's shaped like that. It goes onto the laparoscopic instrument. It's completely clear, and that goes over the port entry. So, and the laparoscope goes through it. So we're still working. Other people are also working on this design. But in theory, any aerosols generated that are coming out, it should mitigate that as well. So there are many things. Some of those, Dr. That Sir discussed, and some of those are being pioneered all over the world. So we need to take the due precautions, but we have to also serve our patients.
Yeah. There's one question from Dr. Harish Udvani. Hypochlorite solution to be used as fumigation. Do you think that OT where cesareans are done, that should be done? May laparoscopy where it should be done? And obviously out of question whether IVF, obviously I'm knowing the answer, but we want to hear from you.
So the WHO has clearly said that do not spray these kind of chemicals on human beings. They're extremely hazardous. And even in the vicinity, we shouldn't do it. So no, I would say that no, that should not be done.
Yeah. There's another thing, I think, so we keep on hearing, and Rutvik Dalal had asked whether BCG vaccination and our history of so much of malaria and taking HCQ and all, does it impart any benefit? That's point number one. That's his question. And what I went through, some important thing is that the average age in Italy wherein mortality was there was 80 years, and the average age which we have in India is much younger, because the young population in India is the largest in the world. So first about the BCG and malaria, and then the age part.
So there is there are a lot of confounders in BCG. So in theory, BCG can have an immunomodulatory effect. It can do certain things to the immune system. We're not sure about all of those. BCG has shown some effects in bladder cancer, for example. Things that we don't completely understand. There is no evidence, really, clinical evidence right now to suggest it helps. There are correlational studies. And you have to understand correlation is very different from causation. So you see, like countries that have universal BCG programs, they also generally have very poor public health systems. So they need universal BCG programs because there is such a high burden of TB. Why? Because they can't test for TB. Why? Because they can't treat effectively for TB. So if they can't manage TB, how are they expected to manage a new infection like COVID? How are they testing adequately for TB? So generally there are confounders like that. There have been other studies that have tried to adjust for those confounders and still found some potential role of BCG. But importantly, these are correlational studies. What we need are clinical trials. So we'd have to administer BCG to individuals and then look at whether there was a difference, statistically significant difference in infection given the same rates of exposure. So right now, no evidence for BCG, but we should research it. The second question was age. So I think, the age skew is also just a factor of our demographics, right? So India does have a very young population. I believe 40% of our population is below 18, whereas Italy has a much higher percentage of people who are older. So that automatically skews the numbers of people who are infected. There are other theories, they're very speculative. So I really want to qualify that they're pure speculative theories. There's no evidence. But there are some theories showing that um, based on certain genetic differences between populations, there are other receptors or genomic variations that might make certain populations more susceptible to viral entry, more potentially feel the effects more than others. It's very early research, but there are many different reasons that are being explored.
And I think so. There were many statements, obviously related to smoking,
Yes.
maybe wine, and so many other things.
Yes.
There were two statements. One made by an intensivist I was hearing on an important webinar, and what's very striking. He told that maybe 1,000 cases of tuberculosis die in India per day, and 8.5 lakh cases of tuberculosis are missed. And this was on a national television. So what he was trying to tell is that we are now responding to COVID very passionately and very actively, forgetting there are a lot of people who are having multiple health problems, may it be tuberculosis, may it be nutrition, may it be hygiene, many other things.
No, in the book, the last chapter we end with, it's called Beyond COVID-19, and this chapter deals exactly with that. If I am not mistaken, by my maths, I think more than that globally, I think around 4,000 people die every day of TB. Maybe I'm wrong. I don't remember the number offhand, but we talk about exactly this, that while many people have somewhat the almost the relative luxury of worrying about COVID, there are women today across the world dying in childbirth, children dying for want of food, and many poor people die knowing that there is a treatment that they cannot afford. So it's really important to remember that the vast majority of humanity is going to suffer in the future of the same diseases they were suffering of before there was COVID. So there are multiple health challenges that face us. COVID is an important issue. It deserves all the attention it's getting. But the other health issues are also important issues and should deserve the same amount of attention. And maybe if we had built a better public health system for tuberculosis, for maternal mortality, then we wouldn't have these issues. Today, what is our biggest health resource? The ASHA program, the accredited social health activists, then almost every village. And that stemmed from trying to respond to diseases like childhood malnutrition, pneumonia, diarrhea, malaria. So it's important when we respond to diseases like TB, we improve our ability to respond to pandemics.
Yeah. Firuza, a very simple question. Rajesh Korodia, we know him very well. The agonist dose as a trigger is 1 milligram or 4 milligram of Lupred. Of course, it's a simple question, but you will know it better.
We use 0.2. So we use 2.
Yeah.
It depends on what you are using. Are you using Lupred? Are you using triptorelin? But by and large, we'll use 2 units.
Yeah. We have 250 questions. Obviously, what we'll be doing is that through BSV and Sheshan, we will have the questions forwarded to Firuza, Swapnil, and myself, and we'll see to it that we answer and we'll give it back. On a human note, I want both of you, and I don't know whether Dr. Meg is around or not, but I want you to, on a human note, what is the biggest lesson COVID has taught you, Firuza and Swapnil? Because, it has really taken us by surprise. On 6th, I got president of ISAR. We had 2,500 people. We had Holi. We had everything kept. And 13 onwards, suddenly the life has changed. And now, so I want your opinion, comments, and your takeaway message, which are more human than necessarily scientific.
Yeah. So Prakash, thank you very much for your introduction of my CV. But my CV has completely changed. Okay. Today, if you ask me what is your CV, I'll say I'm the master chef of the Parekh household. I look after my 93-year-old father-in-law, Dr. Mahendra Parekh. I spend time with him, something which I had not done in the past. I spend time with Rajesh. We usually keep an hour a day in the night where we can sit and chat. We have what is called a family dinner once a week where the children and the significant others are with us. And we take up one topic and we discuss it, not necessarily related to COVID. Here, I would like to say that all of us should be very grateful because we are all in positions where the COVID-19 will barely touch us. Okay? If we get it, we'll go to one of the best hospitals, we'll get the best care, and probably come out of it. Let's look at those thousands and millions who don't have access to basic things. We are telling everybody, wash your hands with soap and water. People are going to tell you, but doctor, where is the soap and where is the water? We are going to tell everyone social distancing. Somebody living in the slum is going to turn to you and say, what social distancing? I am living in 100 square feet with 5 other people. What we should do at this point in time is open up all our government schools, all our colleges which are closed, open up all our parks, allow people who live in slums to go to those gardens, of course practicing all the things. And this is the way we can bring about social distancing and respite to people who don't have the means to do social distancing. Many of our people stay in houses and flats which are 100 square meters or maybe 600, not meters, 600 square feet. Let me give you the example of iftar right now. I had some women who are my surrogates and they called me, doctor, we are having Ramzan going on. We don't know how to break our fast. How do we break the fast? There's no food around. And these are the questions that we as human beings need to address. Of course, there'll be people who will be on the cutting edge of science like Swapnil. There'll be others like you, Prakash, who will do a lot of excellent surgery and take care of humanity from those medical needs. People like Dr. Mandakini, who address the government, who interact with the government, who knows the ground reality. They are our frontline workers. They are the ones we have to take guidance from to tell us in what direction we can go. Sure enough, I can do fantastic IVF in Jaslo. But today I'm proud because I opened my kitchen door more times in a month than I've opened my IVF incubator in a month. So there are many things that should make us proud, many things that must make us human. And if we are all vulnerable, that is when we will truly understand the impact of this virus. In this, I want to thank 3 people who have educated me. Actually, many people have educated me, but Swapnil, Rajesh and Myra have really extended my knowledge. And I'm not an intellectual. I may be intelligent, but I'm not an intellectual. And for this, I'm very grateful because it has opened up my eyes to many things. How people live, what to anticipate, who are we, what have we achieved, what are we in this. We are just microcosms in this large universe. And we still don't know the nature of this beast, as Swapnil said. It's a single strand of RNA, but it has brought us down to our knees. So there is a lot to be grateful for to God and to nature. And there's a lot of things we, as the privileged, can do to help our fellow human beings in whatever capacity we can. Thank you, Prakash, for having me.
Swapnil, I remember few days also where there were 10 years when probably I must be sleeping 3 hours or 4 hours a day. There's so much of work, everything, every phase is there. And today we have so much of time. And very surprisingly, I find that I can utilize the hours which we are getting with family, with other things, with about yoga. I want Ira Trivedi on the screen or somebody else, etc. And all. What I want to know is a young person like you, with so many, feathers around, what it has taught to you after we take the last comment from Dr. Mandakini Meg. Swapnil?
There is a saying that a society is judged by how it treats its weakest individuals. And I think that's what COVID-19 pandemic has taught the whole world. The first rule of a pandemic is that either we are all safe or nobody is safe. In a pandemic, it takes only one person to start an outbreak, and that outbreak can become an epidemic, and that epidemic can become a pandemic. So people who are privileged and have all the facilities, are better off. They can't stay safe if there is an infection decimating, the poor. And think about it realistically in India. This is an imported virus. I mean, it was brought into the country by people who had the luxury to travel. But the people who are going to be devastated by it are the poorest, the people who had no role to play in bringing it into the country. So I think that's what it has taught me, that a healthcare system that forgoes the weakest members is not a healthcare system. It's not a healthcare system that can respond to these challenges. And I think we need to use the COVID-19 pandemic to seriously upgrade our public health infrastructure. That's where we should invest for the next few years, because that's the investment in our future.
Dr. Mandakini Meg.
So thank you very much, Prakash. That I am having my last word, Firoza. I am having the last word.
As always.
No, but not actually very happy to say that. Prakash, I want to draw your attention. Whenever there is any kind of pandemic, whenever there is any emergency, whenever there is a bomb blast, where everything, it boils down only to the government hospital. And here, if you see at the infrastructure, Swapnil will agree with me. Now, if you look at the beds available or whatever things are available, it is either the government or the BMC, related to the government. And rest other hospitals are actually 20% working or 10% they are working. So all the loads of, even I have worked in the government so many years, 40 years almost, everything, any emergency, our all leave is stopped, everything is stopped, 100% attendance in the BMC. Last day, yesterday there was an order. So who suffers is a government staff. Second thing is, even if they are elderly, even if they are, so many medical problems, they say your services will be terminated, but you have to come. So that is one situation. Now look at the private hospital. So private hospital, now yesterday there was a news from the BMC. Now they are short of the food supply to the patients. Now see, everything is exhausting because we were not ready. We were not ready for this COVID. We were trying to bring down the maternal mortality. We were trying to make the BCG available. We have eradicated, in spite of all the difficulties, we have eradicated the polio. WHO has, praised us for that. Also, this MMR has been brought down in Maharashtra. I was a deputy director, RCH, and also in Kerala, WHO against it. So we were trying to do that thing. In the mean between the COVID came. So we all have now is the phase. I want to say to Swapnil that we are now exhausting our resources, be it equipment, be it food, be it whatever it is. Now there is a time. Now, Firoza, there is a time for the private sector actually to come in and help the people. Like, we should not make you compulsory that you treat COVID patient, treat infertility, take emergency. No, but there should be some kind of say Kokila Ben Hospital, say Jasloga. There should be at least some kind of system where one floor is kept for at least mild cases. So you take the burden off from the government. And that becomes so important as a policy maker, I can tell you. And you can also feel what I'm trying to say. So instead of breaking whole government, just now as a ISAR president, as a ICOG person, let us now, even as a Foxy, that let us now try to, take, a stepwise manner to help the government. That is my actually appeal to you all. And I think you will agree with me with this, because we should not, exhaust the resources. The government is doing very well. I must say, even the central government see the policy, see the zones. Once the nozer came to my office, then there was a huge board in my office, and there were MTP cases, Maharashtra government, epidemic, leprosy, everything. And he was looking at the chart, and he was telling, "Madam, so much data." I said, "We are not here to generate data. Data is already there. It is you who are using the data, but we are treating the patient." And that is the reality. So I think let us praise the government, not just on the face or burning diyas and all. It is actually we should praise them because they are really suffering. And I think with this note, thank you very much for such a wonderful discussion, Firoza, and looking forward also Swapnil, Firoza, and Prakash for this wonderful interaction. Thank you very much.
Thank you very much, Dr. Mandakini Meg. And obviously, government is doing extraordinarily well. We are proud about everything what they are doing. We are proud about so many people who are doing. Incidentally, we have an ASRM, ISAR, ESHRI and all, which started at 6 o'clock, which I have to join. Firoza is aware about it. But I am truly honored by such wonderful speakers. And I am also grateful that Preeti, Aditi are next to me, and Somil and our staff. And most important is our patient. And most important is we think about the rest of the people in the world. Thank you very much, everybody. Have a safe and a useful life. Thank you.
Thank you.
Thank you. Bye-bye.
Thank you, everybody.
Thank you very much.
Bye.